Hi there, welcome to my YouTube channel and our ongoing discussion about psychiatric disorders. Today's video I want to talk about personality disorders. Whoa, that's a huge topic. And actually one of my most challenging aspects of my work is treating and managing people with personality disorders. Now, personalities exist everywhere. And so there's been a big debate about how to classify this in a way that we're not over pathologizing normal personality and then not also missing people whose personalities are clearly deviant. Now, personality disorder, I just want to give you a basic definition. DSM has it, others have it as well. It's been pretty much established. It's basically a pervasive disorder of thinking, relating, and perceiving the world from the individual perspective that typically causes subjective distress or impairment in psychosocial functioning. And what does that basically mean? What that means is personality is a very stable aspect of you. You will be you for the rest of your life. Now, you may mature, you may grow, but your core essence, according to personality theory, will not essentially change. There'll be aspects of you that will consistently relate to people in a certain way. They'll consistently perceive things in a certain way, and that will consistently think about things in a certain way. And only when those aspects are maladaptive or inflexible and cause problems will they come to attention, typically of psychiatrists, law enforcement, as a result of boundary violations sometimes, or because they cause you so much distress, you literally can't live the life that you're supposed to live. So people sometimes be holed up at home or not going to work or not in relationships, and that can be very distressing. So if it impacts those things, it's going to cause problems. Now, the question with personality disorders is whether there's insight. In other words, do you know you have a personality disorder? And some personality disorders have more insight than others, and some degrees of insight are greater or lesser on a spectrum as well. And so we want to be able to assess that as psychiatrists to know what tool do we use and how do we go about this in terms of engaging the patient in their own recovery. As I've said many a time in my previous videos, it's never one thing. And you name it, when it comes to the personality disorders, it's never one thing either. It's a combination of therapies, medications, structure, consequences, and someone to support you, because oftentimes people with personality disorders are not happy. Others are not happy around them. And, something has to be typically done about it, because otherwise the problem will persist and breed, as it were, and it's very, very unpleasant for all involved, including the patient. So those are personality disorders. In the DSM and the way other textbooks describe it, we talk about traits, those aspects of you that are going to define you. Everybody has traits. There are about 5 to 6 different traits. I'll list them for you. Obsessive compulsive, borderline, narcissistic, antisocial, histrionic, dependent, and avoidant. So we're talking about 7 different traits there. And everybody will have some mixture of these in their personality. And that doesn't mean that they're abnormal at all, actually. In fact, some of these traits are actually very important for survival. Some of these traits make people very likable. Some of them make people very entertaining. Others can be a bit more annoying, but they're very important that certain people have such qualities. So for example, one's accountant, I would hope that they would have obsessive compulsive traits, because you need to know those details for your tax returns. Your doctor, you would hope, would have some obsessive compulsive traits, because they would need to know details of your disorder and what it is and what it's not, and be sufficiently detail oriented. And successful people are oftentimes detail oriented. Histrionic traits are very important for theatrical people, entertainers, etc. Now, where it becomes problematic is what we call the cluster B personalities. And these are the histrionic, narcissistic, antisocial, and borderline personalities. Of these, the personality disorders that typically end up in the hospital are oftentimes borderline personality and antisocial personality disorders. And this is because they tend to be very intense in their temperament. They can be very externalizing in the way that they handle things, unlike the cluster C personalities like avoidant, dependent, obsessive compulsive, which internalize everything, which causes its own problems. The cluster Bs tend to externalize their problems, and that typically will be loud, aggressive, not rule-abiding, law-breaking, high-octane, fast-driving, sexualized, and again, I'm painting the extreme picture, but I hope you get the picture, because these are the things that typically come crashing and burning into an emergency room or a psychiatric hospital. Oftentimes they'll try to hurt themselves in very dramatic ways, slashing themselves with a knife or threatening to jump off a bridge. Very, very intense and very, very high-octane, kind of like functioning, as it were, from a pathology perspective. So these are the personality disorders oftentimes we see in the emergency room oftentimes and in the acute psychiatric setting. They're not always there. We'll treat plenty of depression and schizophrenia and other disorders in the psychiatric inpatient setting, but these will come crashing and burning into the hospital. I know that because I've done it over decades. So they can be very dramatic, theatrical. Oftentimes they're not very self-aware, and they may need medications to sedate that level of temperament. Anger is an issue. Anxiety is not very well tolerated. Oftentimes they'll be very blaming of others and not have much insight. Now again, that depends on the degree, which is individual to every patient. But typically, they do respond to things like mood stabilizing agents to kind of even out the temperament, even out the bumps, and that is oftentimes reinforced with therapies that help them tolerate distress, such as DBT, dialectical behavior therapy. Now, I'm kind of honing in more towards the borderline and histrionic personality disorders in that way. The antisocial personality disorders are a slightly different kettle of fish, in as much as they can very deliberately be very sly, deceitful, rule-breaking, and kind of defiant of authority. And they know they're doing that, but they still do that. And oftentimes, that is not necessarily helped by hospitalization. They can be a bit like, a fox in a chicken's roost, as it were, in the sense that they can exploit other patients, use, manipulate, and be very toxic to a hospital environment. And actually, for many of their behaviors, they require legal sanctions or very strong limit setting. And like a lot of personality disorders, they may never learn from the experience. They may tell you what you want to hear and go out and do what they're going to do. And I have extensive experience of dealing with such personalities. And really, the goal shouldn't be necessarily to change their personality, but it should be to set limits in whatever setting they are and to give appropriate consequences for rules transgressions or legal transgressions. It really isn't the purview of a psychiatrist to treat antisocial personality disorder. It's been shown that they really don't benefit from individual therapies or group therapies because they're very, very deceitful and cunning and telling people what they want to hear. And it's not clear that they learn terminology beautifully, but it's not clear that they ever really improve. They just go on to become better and better at what they do. They learn from the experience to become more deceitful, more conniving. Most personality disorders burn out by after 40 in as much as they're aggressive, or the cluster B I'm talking about here. The aggressive or self-injurious behaviors tend to burn out as they get older and older. They get kind of tired of it. Their temperament is not so out there, and they may come into the hospital less and less. They've kind of been there, done that, so to speak, and they're getting older and maybe learning from experience. Now, those are the cluster B personalities. Like I said, we oftentimes use mood stabilizers. We can use SSRIs for anxiety, tolerance for impulsivity, because that can be very much a temperamental feature of their behavior. Their behavior is very much driven by their high, kind of changeable, impulsive, intense temperament. And oftentimes they will respond to a combination of mood stabilizers, Depakote, Tegretol, Trileptal, and even the mood stabilizing antipsychotics, Seroquel, Geodon, Abilify. So psychiatrists try a combination, a range of these things, and it really is down to the individual patient. They have to be compliant. Sometimes they're unreliable. By definition, they're very impulsive, erratic. They can be unreliable with their compliance with medications. Some very severe cases may require a depot antipsychotic, which acts as a mood stabilizer, such as Invega, Sustenna, or Abilify, over the course of months and weeks, depending on how severe the personality disorder is and whether they, can give consent for these and even turn up for the medications. Now, the other end of the spectrum is the cluster C, the avoidant, dependent, obsessive compulsive. They're very much internalized. They live in their own head. They will tend to not present for treatment. They feel very guilty for asking for help. They overly blame themselves for things that are happening in the external world. They take on board the world's woes, as it were, in their head and get overwhelmed, and they very much are avoidant of dealing with others. They will not present to the hospital, but they will present maybe to the outpatient psychiatrist with complaints of anxiety and panic attacks, or the lack of confidence. They must present to therapists for that reason alone. And it'll come to light that they've got those kind of that end of the spectrum. They internalize, they worry, they blame themselves, they're very guilt-ridden, and they are very avoidant of change and find change very hard, including, working in therapy or taking a particular medication because they don't trust things, and they'll look for the anxious or, malevolent reason in everything because they just have this trust issues. And then oftentimes personality disorders, there's a reason why they've ended up where they are, because they oftentimes have, impairments in caregiver functioning. I've talked about this in my previous videos. Sometimes they will have faced mountains of abuse, physical, sexual, emotional. Oftentimes they'll have neglect. They will have seen divorce or estrangement from a parent. Whatever rocks their sense of continuity, whatever's modeled to them that is unsafe, unpredictable, scary, frightening, they will tend to internalize that into their own world as their personality develops. So they'll have a view, a consciousness of the world. They'll have a mindset. And that's where the therapy piece comes into it, because they will come oftentimes to therapy or to the hospital or in relationships with a whole bunch of what we call thinking errors. I've talked about this in previous videos. Beneath it all, they don't relate to the world in healthy ways. They'll blame rather than own, and of course you can imagine that doesn't help them navigate life very well. If you're not able to own your own buttons and you're always blaming and you're always cowering from people, or you never learn from experience, and you always marry the same type of person or the same type of character, or he's always falling out in relationships for argumentative reasons, whatever. You're not going to learn from experience. And you're going to have a pretty bleak view of the world, and they'll have an external locus of control in your thinking. So this is very much the pattern of personality disorder. I've just given you an overall flavor. There's two personality disorders that actually look almost like schizophrenia, and they are the schizoid personality disorder or the schizotypal personality disorder. Very few people in my experience actually have schizoid or schizotypal personality. I've rarely seen it. In fact, if they were diagnosed with this, some of them were ultimately diagnosed as schizophrenia. And that's because they are odd, eccentric, they sometimes have magical thinking, they have really out there views of the world. They will think all sorts of esoteric thoughts. They're the ones who believe in UFOs. And, you kind of met some people like that along the way in your life. They'll march to the beat of their own drum. They're going to do their own thing. Sometimes they'll hoard things, they'll have them odd hobbies. They really are disconnected with others. They really live in their own world. And sometimes they may become, frankly, psychotic under stress. That's true of schizotypal disorder. Schizoid personalities just don't need you. They're just quite happy functioning in their own world, doing their own thing. They just do not need anyone. It's surprising because most people do, but these people don't. And so I'm just rounding off the kind of personality disorders, in a nutshell for you. We psychiatrists and therapists in our field, all we try to do is help people function at their best. If there's a problem, right, we want to help people function. And that's why they'll come to us, because they're distressed by that. Or it's affected relationships, or it's caused divorces, or it's caused them to be fired from work, or not be able to get a job, or not be able to seek out a relationship, or their relationships keep failing. We are there to help remedy, I hope, what is missing in that functional repertoire. And if we can uncover defense mechanisms that are unhealthy, or thinking that's unhealthy, or a temperament that bubbles over, that's all we can do. All we ask of our patients is to work with us, to own whatever they can of what we are pointing out to them objectively. And sometimes that can be a bit of a thorny journey. Sometimes they can have what we call transference reactions. If they've always been abused by authorities in the past, like caregivers, stepmothers, dads, moms, sometimes they can take that out on people like us. It happens. It's called transference. It's kind of the oldest mechanism by which patients can relate to others. And we have to explore that and make it what we call a corrective emotional experience, so they don't blur my motives with the motives of somebody else who was a father figure, who was abusive in the past, so they can get a corrected lens, as it were, and not let that lens color all their relationships and all their perceptions of things. So that's oftentimes a very long-term work in therapy, like we call transference-focused therapy, if it comes up as an issue. So these are kind of like all the tools in the toolbox. But what's been shown is that your relationship with your therapist and your doctor is crucial. If you have a good relationship, you'll navigate these difficulties, you'll figure them out, you will move on to the next level in your life, and you'll grow as a person. And that is all that we want to do as healthcare professionals, to help you lead the best life, become the best version of you that you can be. I hope that was helpful. Thank you very much for your feedback. And as always, I want to ask you to stay healthy. See you in the next video.